So as we do always, so Mohamed Mahmoud will be moderating the session. I will be in the background, and we have two appraisers today appraising the two papers. Mohamed Mahmoud, please.
Good evening, everyone, and welcome again for another session. As Mohammed said, today will be pediatric session, and we will start with Amr Mohammed. Uh, Amr, you are here?
Okay, I mean, message him. Just give me a minute. Mohammed, so who is our next appraiser? So I've sent to Amr. I'm waiting for him to reply.
Amr is joining now, so
Oh,
just
okay.
another minute, he will be joining now.
Oh, perfect.
Yeah.
Okay. So guys, this activity is running very regular since November 24. So we speaks this month will be month number 15. Okay. And we're very proud it's running very regular. We have good attendance. It's approved for 1 CPD per session from the Royal College of Surgeons of Edinburgh. And attendance will be evidenced by a certificate, which you will get if you attend at least 80% of the journal club and you fill in the feedback form. Feedback form will bob out once you close the Zoom session. So once we finish the Zoom session, don't close your browser because you will get a feedback form there, which you need just to fill in the form and we'll send you a CPD certificate. The certificate takes about a week to come to your email, which you bought in the registration form. And it's very important for all your practice. So from clinical point of view, it's very important to be up to date with what's going on. So our papers today, one of them will be speaking about supracondylar fracture, which is an emergency every one of us faces in his on calls, either he's a senior or a junior, and you need to be up to date with ways of fixation, difference between cross fixation and three-wire fixation, and what the mechanical difference. So a biochemical difference, a biomechanical difference. I'm sorry. So it's very we always try to get relevant topics, and all the papers are published in a Q1 journal, and we try to get a level 1 evidence, if not maximum level 2. So it's very important for your clinical practice to have an up-to-date knowledge. It's very important to show that you are keeping up to date, that you're attending regular journal club, which is very important for all your applications, starting from ST3 application, interviews for jobs, and especially if you're going to a big center with research facilities. Definitely the Caesar or portfolio busway application, you need to show that you are attending regularly a journal club at least 6 times a year, so at least 6 journal club a year. And the more you show regular attendance, the more your evidence is robust. So I think this was mainly why we get this to run very, very regular every month. So it is a lot, needs a lot of work in the background behind the scene, but we keen to give you all the chance to keep up to date knowledge-wise, and at the same time to have the required credit or evidence for your applications. So keep as regular attendance as you can. So CPD certificates is very important for your appraisal. It's very important for all your applications, and that is a clear research experience, a clear critical appraisal skills and knowledge, which is regular attendance journal club. We open now for the second cycle of the year, which is from June 26 till December 26. We are happy to accept new appraisers to run through different subspecialties. We make it a specialty every month. So if you're keen to share, to come and join our appraiser team, we are more than happy for that. We put an announcement and we send an email with all the details. You need to just email the team at journalclub@orthoexcel.co.uk. So the email is journalclub@orthoexcel.co.uk, and just show your interest. Send us a short CV just showing your research experience. Then we will get you the paper, because we try to choose our paper, as I mentioned, very relevant and Q1 in a Q1 journal, and as much as possible level 1 evidence. So we'll send you the paper. All what you need is to just exercise your appraisal and appraiser and critical appraisal skills. So get a proper presentation. We have a quality team which will be looking into your presentation and help you with a commentary about your presentation, which is very, very useful even for your own knowledge and for making this very regular. So it's very governed, it's very quality assured, and it's approved for one CPD by the Royal College of Surgeons of Edinburgh. So it carries all the weight you need for all your applications and appraisal. So please do come and regularly attend the journal club. And please remember to put the feedback, so we'll be able to send you the CPD certificate. So I will leave it now to Amr, our first appraiser, to share his screen and start the first presentation. Amr, please.
Hello,
Hello.
everyone, and sorry for this delay. So we'll start with Amr. Amr, he is a senior clinical fellow in Lucian University Hospital, and he holds an associate professor post in Ain Shams University, Cairo, Egypt, and he will present a critical appraisal on the systematic review of the seasonal instance of slipped capital femoral epiphysis, which is quite recent, published in May 2025. So I can see your screen. You can start, please.
Hi, good evening. Thank you very much for giving me the chance to participate in the journal club. And thank you very much. And I'm really sorry for the delay. I just I got confused with the timing. I thought it starts at 8. So sorry about that. So as you mentioned, the article is regarding the assessing the seasonal incidence of the slipped capital femoral epiphysis. It's both a systematic review and meta-analysis. The article was received on the 30th of April 2025 and published on the 31st of May 2025. This is one of the fastest papers to be accepted. So the journal basically is a pediatric journal. It's the journal, a children's journal based in Basel, Switzerland. And it has an impact factor of 2.1, and it's a Q2 journal. If you search for it in the children or the pediatrics journal, it's a Q2. It doesn't have a rank according to the Web of Science as an orthopedic journal. So it's a fairly strong journal. The authors, there are 6 authors in total, and the first 3 are medical students. The 4th author is a statistician, which gives this article very strong statistical analysis. And the the last two or the most senior authors are both consultant orthopedics in Wisconsin, the US. Their aim is to assess, is there a seasonal pattern of the incidence of the slipped upper femoral epiphysis? And their methodology, number one, is the study design. As we mentioned, it's a systematic review and meta-analysis. They didn't mention in their original text the level of evidence but I think it's level 3, as most of the papers that used are retrospective study. It's observational epidemiological study. There was no intervention in these studies. They conducted their strategy according to the research according to the PRISMA guidelines. They searched the PubMed, Scopus, Web of Science, and Ovid platforms. They used combined keywords, meaning that each paper has to contain these four phrases or these four keywords: SOFI, seasonal variation, monthly incidence, and epidemiology. They didn't put any restrictions on the year of publication. They moved on and they removed any duplicate records, meaning if the same patient cohort were mentioned in 2 times, they will remove the duplicate, not to create confusion by mentioning or including the patient cohort twice. Then they moved on. They did title and abstract screening, and if the papers pass this step, they will read the full text review. And then this method was done by the three independent authors, the medical students, the 3 junior authors, the first 3 authors. And if there is any disagreement or disagreement about to include or not to include the article, they will resolve this with discussion. Their inclusion criteria was any paper that contains pediatric population diagnosed with SOFI, and the study should report or must report seasonal or month-by-month incidence. They included only, as I mentioned, observational studies, and the studies. They also conducted the subgroup the studies according to the geographical location, according to the latitude. They excluded any study that has duplicate data or duplicate patients cohorts, or if the study did not report any seasonal incidence, or there was interventional studies or biomechanical cadaveric, any study that is not studying or not researching the seasonal incidence. They excluded all of these studies. This is the original flow chart, and I summarize it here in this slide. So they identified 60 articles at the beginning. Out of these 60, they removed 32. They left with 28 records. The 32 were duplicate articles. And then they excluded based on, they excluded 5 more based on the title and abstract. They did not meet the criteria. And then they excluded 10 more after reading the full text. So they left with 17 articles after adding 4 articles more identified from the citation, meaning that they read the article and they can pick from the references part of the article. So they picked 4 more to include. So the systematic review was done for 17 articles, and they did the meta-analysis using the Cosinor regression analysis for only 6 studies. These are studies that are including the month-by-month incidence. So the articles that included the seasonal variation in general, there were 17. These were included in the systematic review. And they did the statistical analysis or the meta-analysis on 6 studies only. And these are the one reporting the month-by-month incidence. They tabulated their data in Microsoft Excel, and then the variables that they were looking at, the study location and the latitude, the number of patients, the presence of seasonal significance, and the month-by-month data. Seasonal significance like autumn, summer, winter, month, the 12 months in the year. Again, 3 independent authors, the first 3 authors reviewed the data, and then any disagreement was solved by discussion and reconciliation. So as we mentioned, the subgroup, the studies according to the geographical location. So 14 studies were done above north to the 40th degree latitude, and only 3 studies were done south to the 40th degree latitude. So, and again, they used the Cosinor regression analysis using the R software. So this is the 40 degree latitude north. You can tell. So the studies that were included in the meta-analysis were mainly from North America and Europe. So the results, they included 21,428 children. These are the total population of the 17 studies that were included in the systematic review. Only 12 studies were reporting statistical significant seasonal variation. And as we mentioned, out of these 12, only 6 reported the monthly variation and were included in the meta-analysis. The studies that were south to the 40 degree north were only 3. One of them showed seasonality, or there is difference in the incidence as per season, and 2 studies neither showed seasonality or reported monthly incidence. So all the studies below the 40 degrees north latitude were excluded from their study. So the systematic review showed that there is a peak incidence in the summer, and the meta-analysis showed that it's mainly in August, and the lowest incidence was in February. And again, the meta-analysis was done on 6 studies only, based on the month-by-month incidence. And this is the chart retrieved from the meta-analysis. You can tell here that the month of August carries the highest risk for highest incidence of slipped upper femoral epiphysis. Now to the critique. I usually do it by each part of the article. So the strength that this is a well-written article in general, and it is published in a fairly strong journal, Q2 journal, with 2.1 impact factor. There are some limitations to the study in general. It's only observational retrospective studies, is not prospective. It's level 3. It's latitude restricted, which carries selection bias. You only pick your patients from certain geographical area. So you cannot generalize your outcome for the general population outside this geographical area. In the abstract, they did not refer to the fact that only 6 out of 17 studies were included in the meta-analysis, and they did not report the level of evidence. It should have been reported in the abstract. The introduction is relevant, but there is limited discussion on how seasonal findings could directly alter the current screening or referral pathways. They have clear aim in the introduction. They mention the aim in the introduction, but the rationale behind this aim, why we are searching for the seasonality or seasonal variation on the incidence of the slipped upper femoral epiphysis. They did not justify the reason of conducting this meta-analysis. Their methods were robust. They had a statistician on board, so they did very good work with the statistical part and the statistical analysis of the meta-analysis. They used a relevant statistical test, which is the Cousineau regression analysis, which usually used when you want to see changes over time rather than comparative between two intervention or between two groups. However, they did not report any study between study heterogeneity, which they did not report the variability between the studies that they included, the 17 studies. And they did not do an assessment of the publication bias using a funnel plot or anything like that. The results were clear and well reported. However, again, they did not refer to the included 6 studies, despite 17 were included in the review. In the discussion, the good thing about it that they acknowledge their limitation. They acknowledge that there is a potential reason to explain the increased incidence of the SUFI during the summer month. During the summer month, there is usually an increase in the physical activities of the whole population, including the children, which might explain why children might get slipped upper femoral epiphysis in general. I think if we conducted a similar meta-analysis or a systematic review for all orthopedic trauma and skeletally immature patients, you will find increased incidence in the summer months. There is another thing with the hot weather. There is an increased growth rate. So this as well might be the cause of the increased incidence of the SUFI in general. Again, in the discussion, they did not discuss what is the value, how the finding could affect our practice. The language and the style are relevant and clear. The tables and figures are adequate. Usually when I do at the end, there is a reflection and take-home message. This is my layout for this slide. However, for this one, I will take another approach. Yeah, the study demonstrated statistical significant seasonal variation in the incidence of this slipped upper femoral epiphysis. However, these questions jump in immediately. Is there any more favorable prognosis for patient diagnosed in summer versus winter? does the rate of complication differ during summer or winter month? Is there any increase in missed SUFI during the summer or winter months? Is there any change in the management plan? I don't have any answer for this question because the authors didn't answer it. They did not give us any explanation why we are conducting this study, what we want to achieve. Until further evidence, seasonality does not change either the decision making, the management, or the complication or missed cases. It's a very good, is well-written journal, well-written scientific article, but the clinical utility is limited, as diagnostic vigilance for SOFI should be maintained all over the year. Because the diagnosis, the management, and the consequences of missed SOFI are unchanged by season. There is another thing that emphasizing seasonality is a double-edged weapon. I'm not sure if we should stay vigilant during the summer month and just be casual during the winter month. So I don't think that I can hardly find a clear change that I will make in my own practice based on this article. But it is, in general, it's a good observational systematic review. Thank you very much.
Thanks, Amr. That's very nice and thorough presentation. And I think, yeah, it's very fair appraisal of the paper. But do you think, can we change like the management pathway? Like we can, I think from the distribution of the incidents during summertime, especially the late summer, I think it may raise our attention. Like, there's a very commonly missed injury, especially from juniors in the ED. And yeah, I see what you're coming from. So it's not a clear message about clinical value of the paper. But I mean, can we get from it like a pathway, like in late summer, especially in late summer, the suspecting and SUFI should be higher, getting like more X-rays for adolescent hip injuries or adolescent knee pains, which is a very common presentation? Or do you think that just will be an overacting?
No, I think the paper was published in a pediatric journal, not an orthopedic journal. So I meant the target audience, I think the target audience were the pediatricians rather than the orthopedics. Again, as well as the GPs. So I think if we want to make the clinician to be more aware of it, I think the target here were the pediatrician and the orthopedics. Me as an orthopedic surgeon, it doesn't matter if the child comes during winter or summer. I will do the same, exactly the same. So I don't think for orthopedic surgeons it's gonna change much, but it might raise the awareness amongst the pediatricians and GPs.
And it's a fair point. So you know that this either GB or pediatrician, they are the ones who really receive this patient. And if they have in the background the outcomes of this paper saying that in the late summer, the SOFI is very expected. So please, if you get a patient with hip pain or knee pain in an adolescence, especially if obese, have endocrinopathies or any problem like that, go and have an X-ray or at least refer to orthopedic at some point. So, and I understand where they come from in the paper. So that is very common missed injury. And they're trying to find a way to create like, a flag or like an alarm or like a red flag saying that, oh, that's very common in this time. So in this time, if you get an adolescent with this problem, please take it more serious or take it more in depth. For an experienced orthopedic surgeon, it will not make a big difference in your practice. But I mean, as a general pediatrician, GB, junior orthopedics, it still gives them a clue that by this time, keeping an eye on that. Guys from the floor, do you have any comment on that? So if you have any question, keep it in the chat, or you want to unmute yourself and come in with your question, or even sharing us in this discussion. Do you think we should do something different? Should this push us to get a pathway like we're doing, like the Grift is doing now with a lot of ED conditions, a lot of emergency orthopedics. So in the next few months, you will see a lot of ED protocols. The Grift has conducted visits to every ED in the country, and they will be coming very soon with a lot of pathways. Should this paper be a start point for a pathway for the SOFI, especially regarding seasonal variation, regarding geographical variation? Shall we run some studies about geographical variations, about common presentations? I know it has been studied before, but I mean we're still in front of a commonly missed injury, which is very critical for the patient and is very common to miss by the junior orthopedics, which they are the first line who really receive the patient. So the patient will not see a consultant, the ED, he sees a junior orthopedics. And the missed injuries in this type of injuries is more than 30%, which is a lot. And this patient, if missed, the results are very bad. Any comments, guys, from the floor? We need to see the pediatric experts coming
There's
in.
no comments at all in the chat.
Okay.
Yes, I
Hopefully
think
that's
your
that's
So,
user was quite
yeah,
clear. Thank you so much for that.
exactly, yeah.
you're welcome. Thank you. So just a question for you, Mohamed, because you mentioned, because I was thinking about, does seasonality, if you are creating now a clinical pathway for the diagnosis of SOFI, and you will post it in the AD and in the GP office, does the season will make, how are you formulated in light of this article?
Yeah,
Will
so
include, yeah,
yeah. So from the new graft coming, there is some pathways about the socioeconomic. So some areas especially will be like if you come to certain areas, this hospital in this place. So be careful that there is with a low socioeconomic, there is a high instance of diabetic foot, for example. Okay. And I haven't seen till the moment anything about seasonal variations. So pathway which speaks about different seasons. But
exactly, yeah,
yeah, but I mean, these new ideas are coming in. So we never spoke about socioeconomic before. So all pathways are general for every injury, but now you will see new pathways specifically for socioeconomic areas. And I don't think seasonal variations will be far away. So at some point we'll start to speak about seasonal variation. It's all these efforts is about reducing the times we miss these fractures or these injuries, whatever the injury. Get my point? Till the moment, I haven't seen a pathway concentrating mainly on seasonal variations. But again, we haven't seen before anything about socioeconomic, which is coming in the way. So at some point, you'll find that if you're working like in Losham, okay, so you find by work if you're working like in Northeast, for example, for in these areas of trust. So please be careful. This is the pathway for like very common. Patient comes very late with coda equina. So you have a lot of coda equina already coming late after missing the golden hours. Diabetic foot is very, very common. So socioeconomic and diabetic foot is coming in the way. So there will be a guidelines about that. So I'm not, I'll not be surprised if I see a seasonal guidelines or pathway coming very soon. And I think in States, they start thinking about that, and this is where this study came from. Good. If no more question, guys, can we pass to the next appraisal and next paper? Amr, thank you so much for your time and thank you so much for the presentation. It was very, very helpful, and I think, you've done a very good job. Mohammed?
Thank you again, And now we have the second speaker, Mahmoud Ali. He is a junior clinical fellow in North Manchester, and he will be presenting the critical appraisal of another meta-analysis of randomized control studies, talking about the medial and lateral versus lateral only pinning fixation of displaced supracondylar humeral fracture in pediatric. This paper has been published in 2023. Mahmoud, please, can you start sharing your screen?
Hello, everyone. Can you see my screen now?
Yes. Yeah.
Hello, good evening, everyone. My name is Mahmoud Ali. I would like to thank Mr. Hashim and the panel for giving me this opportunity to present this critical appraisal. I'll be talking about this appraisal for medial lateral versus lateral only pinning in children, supracondylar humerus fracture, a meta-analysis of randomized controlled trials. Just a quick background about supracondylar humerus that was mentioned. It is one of the most common elbow injuries in pediatrics, and closed reduction and percutaneous pinning fixation remains the standard management in displaced fracture. Gartland classification divided into 4 types: type 1 non-displaced, type 2 and 3 displaced with type 2 and intact posterior cortex, and type 4 with multidirectional instability. The 2 configurations mentioned are the medial lateral pinning and the lateral only pinning. This remains a common surgical dilemma and still debatable with which configuration has the superiority. Regarding the title of this article, it is a systematic review meta-analysis of randomized controlled trials published in the Journal of Orthopedic Surgery and Research in 2023. From the title, it gives a clear title and addressing a common surgical dilemma, and there is still no consensus or consistency of the superiority. Regarding the journal, it is a Q1 journal ranked as 9th with an impact factor 2.4. Sorry. Mr. Nicola Maffoli regarding is a consultant in musculoskeletal disorders in University of Rome and honorary chair in sports and exercise medicine in University of London, Queen Mary. It is peer-reviewed, indexed in PubMed and Scopus. Regarding the authors, there are 3 authors. All are from Department of Trauma and Orthopedics in Yunshan Central Hospital in China. The article was received in October 2022 and was accepted in January 2023 and published also in January 2023. So this shows a short time for editing and quick acceptance and publication. Introduction regarding PICO population involved was children with displaced Gartland type 2 and 3, with some trials including type 4. Intervention was medial lateral pinning, including studies using mini open medial approach to reduce the ulnar nerve injury. Comparison to lateral pinning using 2 or 3 pins, and the outcome assessment was for loss of reduction, iatrogenic ulnar nerve injury, radiological outcome, Flynn criteria, pin tract infection, and elbow range of movement. It is concise and to the point. It emphasizes the no consensus of which pinning configuration has superiority with the surgical dilemma regarding providing biomechanical stability versus avoiding ulnar nerve injury. It gives an updated meta-analysis with more recent published randomized controlled trial comparing the risk of ulnar nerve injury and fixation stability. Also, cosmetic outcome for both groups in children with supracondylar humerus. The methodology is a PRISMA design. They searched randomized controlled trials comparing both groups in literature database, including PubMed, Embase, Web of Science, Cochrane, and Google Scholar. up to April 2022. There was no language restriction. It was not restricted to English only. The keywords involved were supracondylar fracture, humerus, or K-wire, pediatric children, or pediatric. Reference list included articles were reviewed for additional eligibility, and there was an appropriate inclusion and exclusion criteria. The data extracted were conducted by 2 independent authors, and any discrepancy was resolved by full discussion to achieve consensus. The inclusion criteria, Gartland type 2 and 3, closed reduction and percutaneous spinning, and randomly assigned patients. The exclusion criteria, they excluded non-randomized controlled trials, Gartland type 1. There was no sufficient data, abstract or meeting conferences. Overlapping samples were excluded. Only the large sample or the most recent sample were included, and non-standardized fixation methods were excluded. This is a flow chart for the PRISMA. It included identification of 809 randomized controlled trials. After screening and removing of duplicates, it ended up with 327. And after going through the exclusion criteria, it ended up with including 19 randomized controlled trials. Regarding the involvement of 19 randomized controlled trial, it was 1,297 patients that were included. Statistics used Stata version 16 was used for meta-analysis, and I-square statistics and Cochrane Q-test to assess heterogeneity. Random effect model for all analysis to gain more conservative pool, and subgroups were pre-specified depending on Gartland type, mini open technique, and the use of third pin. Relative risk was used for assessing nerve injury and loss of reduction, mean difference for angles. A funnel plot and eager test used only when more than 10 studies were available. Trim and fin analysis appropriately performed. Regarding the study, as mentioned, they included 19 randomized controlled trial, and 1,297 patients were divided into 2 groups. The medial lateral pinning was 648, and the lateral pinning 649. 10 randomized controlled trial included assigned Gartland type 3, 8 randomized controlled trial assigned Gartland 2 and 3. 1 randomized controlled trial involved 3 types of Gartland 2, 3, and 4. 6 randomized controlled trials allowed third pin fixation if required, and 7 randomized controlled trial included mini open approach for medial lateral pinning. The follow-up was 1.8 months to 11.43 months. Regarding the risk of bias, this is diagram from the study showing that 4 trials had high risk of bias of random sequence generation. 5 randomized controlled trial without reporting randomization procedure were considered to have unclear risk. Other 10 randomized controlled trial had low risk of such bias. 5 studies reported proper allocation concealment, and 3 trials had patients were not blinded to intervention with high risk of performance or detection bias. The overall risk of bias in most was identified in most of included studies. The results show that loss of reduction was reported in 10 studies, around 806 patients, 52 patients in cross-pinning with 12.8% loss of reduction, compared to 81 patients, which is 20.2% in the lateral pinning fixation. The incidence of loss of reduction in the mediolateral pinning group was lower than the lateral group, with significant difference. They further divided the analysis into several subgroups. In patients with Gartland type 3, the mediolateral pinning reduced the risk of loss of reduction. In addition, patients receiving mediolateral pinning without using a mini-open technique had a lower risk of loss of reduction. They didn't find significant association of pin configuration with risk of loss of reduction in subgroups allowing or not allowing a third pin. Also, they assessed loss of carrying angle was compared between both groups, and this was in 7 randomized controlled trial, and loss of Baumann angle in 10 trials. There was no statistical difference between both fixation method regarding these two angles. And also there was no difference in the radiographic outcome for loss of humeral capitellar angle and metaphyseal diaphyseal angle. For functional outcome, according to Flynn criteria, this was assessed in 15 trials, and for the mediolateral group, it was 74.9% as compared to the lateral group, 70.8%. It didn't show significant difference between among all subgroups in terms of fracture type and use of mini-open technique. The other outcomes for assessing, including loss of elbow extension, flexion, range of movement, didn't differ between both groups. For iatrogenic ulnar nerve injury, this was compared in 18 randomized controlled trial. 6 studies observed no injury in all patients. Incidence of iatrogenic ulnar nerve injury was 5.4% in the mediolateral group and 1.3% in the lateral group, which was significantly higher in the mediolateral pinning configuration. On assessing mediolateral pinning group with mini-open technique, the incidence of iatrogenic ulnar nerve was 2.2% as compared to the lateral group, which did not differ significantly. Regarding pin tract infection incidence, it was not significantly different in both groups of configuration. Regarding the sensitivity analysis, it showed that one study had a significant influence for the pooled estimate of loss of reduction. They excluded this study, and the mediolateral configuration was no longer significantly associated with the risk of loss of reduction. For other analysis, the pool results were not significantly changed regardless of which study was omitted. Asymmetrical funnel plot was found in analysis of loss of reduction, and eager test indicated potential bias. However, after trim and fill analysis by inputting 4 studies, the association was not significant anymore. For other meta-analysis, the funnel plot were symmetric, and eager test indicated no obvious evidence of publication bias. They also conducted a great assessment of certainty of evidence. The certainty of evidence of pooled effect estimate was graded very low in analysis of loss of reduction, iatrogenic ulnar nerve injury, and pin tract infection. Also low in analysis of excellent Flynn criteria, loss of Baumann angle, and carrying angle. Regarding the discussion, it was concise and clarifying, comparing with comparable functional and radiographic outcomes between both configuration. Optimal choice regarding iatrogenic ulnar nerve injury and loss of fixation is still controversy. Mini-open technique does reduce the risk of ulnar nerve injury with the mediolateral pinning configuration and with comparable safety as lateral pinning. Disadvantage of mini-open technique, it has a longer surgical duration, with a surgical scar. The results suggest that cross-pinning fixation with a many open technique is an effective and safe treatment strategy, especially when trying to achieve more stability in unstable fractures. Higher chances of loss of reduction was evident in the lateral pinning group. The limitations of the study, authors agree with limitations. There was poor methodological quality. Most randomized controlled trials have unclear or high risk of selection performance, detection, reporting bias. Small number of participants in the randomized controlled trials, and the overall sample size was limited. The high clinical heterogeneity in terms of duration of follow-up, the fracture type, number of pins, clinical experience level of the surgeon, and delay of surgery, which can all have impact on the clinical outcome. Subgroup analysis regarding divergent or parallel configuration of the lateral pin was not conducted due to insufficient data. References included, it was 46 reference with good quality references and relevant topic. This article was cited 10 times, and majority of references were recent. Just few points for appraisal. The results may be disproportionately influenced by the small or methodological weak randomized controlled trial. Also, the heterogeneity was often statistically low. Clinical heterogeneity, including the fracture type, number of pins, surgical technique, and surgeon experience, was substantial but not quantitatively addressed. After trim and fill, the significant result of loss of reduction disappeared, which is undermining confidence. And many subgroup analyses were underpowered with increased type 1 error due to multiple subgroup comparison. Reliance on p-value without emphasis on effect size and no adjustment of multiple comparison, increasing the false positive risk. So, was this study useful? It was very useful, and it is reproducible. However, the conclusions are not robust. It is moderately reliable, but not enough to change practice evidence. It is applicable, and it will not change the practice regarding this article. For practice, lateral pin remains the first line for most of Gartland type 2 and 3 fractures, unless there's question about the stability or medial column comminution, rotational instability, then achieving more biomechanical stability is required with cross-pinning and using a medial approach to protect the ulnar nerve. The strengths of this study, it is directly relevant to pediatric orthopedic practice and address a common surgical dilemma. The limitation is short follow-up in many trials and variation in surgical technique and expertise. Thank you for your attention.
Thanks, Mahmoud. That was very, very good. So, and supracondylar will stay the commonest topic in pediatric orthopedics we face every day. And I think all these studies are coming from the point we're trying to escape from ulnar nerve and medial equality. And to be honest, in my practice, my own practice, I use a couple or 3 lateral wires more than median lateral wire. If we have to open medially, I have to do a mini open. So I prefer to go for lateral unless there is varus or rotational instability. So in my own practice, I go for a couple of lateral. And I think the key point is the reduction. So if your fracture is reduced, the 2 lateral wires is doing the good job. I don't think I have any problems with any of my patients. Especially this one as well have some seasonal variation. So really in summer, especially nighttime, we have a lot of supracondylar cases. So, and back home when early years of training in Egypt, so we receive 5-6 cases every day. So I think lateral wires are doing the job unless you have a varus or a rotational instability. So I think the paper is still very valid, and it's a hot topic. It's a lot of discussion going on about it, and I just disagree with you in the follow-up because you need to see an union, so you don't need to go for a very long follow-up. So it's an operative technique. So once it achieves the proper reduction and maintain the reduction until the fracture is united, job done. So yeah. Biomechanically, I know that there is the two wires will be a bit stable, but there is a lot of debate about this stability, especially about the configuration of the wire. So it's not only crossing wire or parallel lateral wires, but how much divergence you have in your wires, how they are diverted at the fracture site. So if you put a cross wire with the crossing coming at the fracture site, the rotational stability is not the greatest. So it's again, it carries a lot about the technique itself, not only the configuration of the wires, but yeah, it still adds to the evidence. It still, as you mentioned, reinforce the practice. So I know that a lot of non-pediatric orthopedic surgeons are going now to lateral and avoiding as much as possible to put a medial wire. And I think this paper will back up them and give them a support. So guys, anyone have any different practice in this? So imagine you are in theater and you're reducing a supracondylar, Gartland 3 or 4, and then you put your two lateral wires and you're scanning your fracture dynamically under screen, and then it's still in varus or rotational instability. Will you put a third wire lateral or you put a medial wire?
I will put medial wire.
Yeah.
So many of the approach.
Yeah. The problem is the good thing is even the cases I've seen with underlying symptoms, they still come back and they still have a good results, but it's just devastating for the patient and family to have a nerve symptoms for a while. So I think I think the paper is well written. I think the paper has a good message. Even with every paper will have some drawbacks and some negative points, but for me, it's a good paper, and I think the message coming from it really reinforce the practice. So we need more and more support and backup for putting lateral wires and avoiding medial wires, especially we are not pediatric orthopedics. If you are a pediatric orthopedics, so you do whatever you want. If you put both lateral, one medial, one lateral. For me, as a non-pediatric orthopedic surgeon, I think still it is the reduction. Achieving a proper reduction is the key point. Then choose whatever configuration, but do it properly. So properly means see your angle where the crossing of the wire will be. If you're doing a lateral wire, make it divergent at the fracture site to the maximum. So span long as much surface area of the fracture as you can. So maintain rotational stability. And definitely we speaks about a fracture with intact medial column. If the medial column is gone, you're left with no option except to put a medial wire. But if the medial column is intact, I think from my practice, it is the two lateral wires are doing a good job, unless there's varus or rotational instability. Any question about this paper, guys? So you are free either to pop your question in the chat group or to come in and mention it. So Mohamed is saying we're publishing a new technique of using transthyretin wire and a lateral wire. That's great. So we will be waiting to see it, because anything which gets us away from the ulnar nerve will be very thankful to have it, especially if it's have a good follow-up and a good number of a good sample size. We'll be like waiting very cautiously to see it, and we'll be more than happy to use it if the technique is very valuable. The point is here in UK especially, the medical legality about the medial side is very high. Half of the pediatric orthopedic surgeons have their problem coming from the medial wire and ulnar nerve. Yeah, Mohamed Galhoum is a post-TCT fellow, pediatric fellow, and says that transthyretin add more stability, of course. That's very good. So we're waiting for that. I haven't done transthyretin before, but I will be very happy to do if this is achieve the stability and have a good results published. anything getting us away from the medial side will be more than happy to do. Yeah, 42 cases as a start is very, very good. So Mohamed is saying we did 42 cases. I think that's a good number of cases, especially if you have complete follow-up for the 42. So
I'm sorry, I have a question.
Sure.
What do you mean by trans-olecranon wire for this?
Yeah, I haven't done it myself, but the publishing on it. So
Mohammed Ismail, can you unmute yourself and just explain a bit more about the trans-olecranon wires?
Yeah, hi everyone. Yeah. So we are aiming about the trans-olecranon wire, usually, especially in the hands of the junior trainees, because we have seen that, especially in the junior trainees, that especially if the elbow is swollen, sometimes there is multiple trials through the lateral condyle in order to fix the supracondylar fracture. So our paper is that you put one wire, trans-olecranon, going through trans-olecranon, going into the distal humerus. Then you fix the fracture now, and then you can put another one lateral wire. 4 weeks, you remove the wire, and no affection on the range of motion, no infection, nothing happened. And it is a very, very rigid stability, no loss of reduction in any of the patients, no nerve injury. It was very easy. Most of the junior trainees, the maximum trials was 3 in order to put a good trans-olecranon wire. So this was
Does it carry any risk for the articular surface and
we haven't
injury?
seen any risk, any injury to the articular surface. We haven't seen any stiffness. All the patients have regained their normal range of motion. We have only one patient of the wire is broken intra-articular, to be fair, but this has some circumstances regarding the follow-up of the patients and the family and all of this. And we operate the patient again to remove the wire. This was the only complication we have from the 42 cases.
That's quite interesting. So
Okay, sorry.
Is it coming soon?
Yeah, we submitted it. We did some. We are waiting for the decision now.
Okay.
Okay, so sorry, I missed this part. I came a bit late. I thought it's trans-olecranon fossa, not trans-olecranon itself. So
No, from the olecranon itself.
okay, so that would be interesting because yeah, when I said trans-olecranon, I was thinking about trans-olecranon fossa because that's always my aim is to go. I start always with my, you bought two. So my aim is always to have. If you bought 3/3 of the articular surface of the distal humerus, I divided it by 3, and I aim for 2 columns out of the 3. So I start my wire, my 2 lateral wires. I start with the medial one, and aiming to that olecranon fossa, so it comes low, and the second one will be the most lateral wire, and then will be very steep to catch slightly proximal to the distal humerus. And then you'll achieve 2 columns out of the 3. And I think this is stable enough because once you go through trans-olecranon fossa, you are taking 4 cortices, not 2 cortices. And the most lateral wire catch 2 cortices, you are talking about 6 cortices in that case, which should be more than enough for supracondylar humerus for a kid. But I've never seen trans-olecranon trans-olecranon itself. It'll be interesting to see the results.
What we have seen that once you put the trans-olecranon wire, you don't need to maintain the reduction.
And you leave it completely. You don't take after you do the 2 wires. You don't take it out.
No, we put only one lateral wire with the trans-olecranon wire. Only one lateral wire.
And
we leave it 4 weeks.
What is the elbow? Is it flexed, extended?
90 degree.
Should be flexed,
And it will be intramedullary then. You leave it approximately intramedullary.
No, not intramedullary. It exits through the lateral cortex. So we have variation. So some of them come through the lateral, some of them come through the medial cortex. We divided them into categories, and some of them are intermedullary also.
Oh, it'd be interesting. Okay.
Yeah, really interesting. So yeah, and I
No,
think it
but-
will raise a lot of discussions. And but really,
Hopefully,
yeah, if it's doing a good job in your hand, why not?
once the decision, we'll put it in the group. Hopefully, it will
I
come
mean,
soon.
that's all the practice in Egypt. I mean, for like very senior consultant for elbow dislocations, when it's very unstable, to put one transolecranon wire until they do reconstruction. I mean, yeah, this is not the practice in the UK, and I'm not sure this is the current practice overall in the world. But I think it was
To be fair,
previous practice for adult supracondylar, adult elbow dislocation, unhappy triad or terrible triad to put transolecranon wire.
We are not the first to do this. There is a paper published from India. It's called Sharma et al. And they did also about 45 patients, and it is a very nice paper about this also.
Okay, that will
Yeah, we can check that. Yeah, we can even get it to the next
Mohammed,
pediatric
can I
consultant.
ask you a question?
Yeah, you
So
can.
what's your point of entry? Like you take a lateral wire, which is as you aim to hold the distal fragment laterally from the lateral epicondyle, I think, and then you go for the medial column proximally. So
Yeah.
for transolecranon wire, where is your point of entry? Where do you go?
Same. We're going from the lateral part of the olecranon, laterally also.
Okay.
We found this is the best. This is the best and the most rigid stability. And to
then
come
you
over
aim for
the cortex, for the medial cortex.
of like the medial column. You aim for the
For the medial
medial
column, yeah. Yeah.
So Amr is like,
Is it parallel?
you know,
Is it parallel to the
Parallel or
other
crossing,
wire
yes.
or
Yeah,
cross?
yeah, so
the
they
best of them
come
is
more
always the
distal.
parallel.
Yeah,
Yeah,
I know.
basically more distal.
Become more distal.
Yeah.
Then is it parallel to the first wire or?
It's not that parallel, to be fair, but
So what's your aim? Diverge or converge or parallel? Like what do you want to do?
we want to do the aim of our
No. The aim of you started the surgery. What's your optimum position of the wires? You do put the lateral wire first or the transolecranon wire first?
no, the transolecranon wire first, because our aim is to reduce the number of trials through the lateral olecranon, the
Okay.
lateral condyle of the humerus. This was
Yeah.
especially in the swollen elbow. This was our aim.
So, Muhammad, you are saying that the transolecranon wire will be quite easy to hold the reduction, and then you will fire the
stable.
lateral wire?
So what we have seen, I told you, our aim is to assess it in the hands of junior trainees. Junior trainees 1 and 2 years of training.
Okay.
So
Yeah.
what we have
No,
seen
sorry,
comparable.
Muhammad, we are not asking about like the methodology or the aim. I'm asking about the technique itself. What do you do in order to achieve it? Like you start first with the transolecranon wire first, then you put the
Transolecranon
lateral
wire
wire
first, and
and
then
you
after
start
that,
lateral from the lateral surface of the olecranon. Isn't it?
yes, yes,
And then you aim to hold the medial column proximally,
yes,
proximal to the
yes,
fracture, isn't it? And then
yes,
you take the lateral wire after that.
yes.
Okay. And your best position will be like not parallel, not divergent, not convergent. You don't aim for something. Doesn't matter. Doesn't make a
No,
difference.
no, yes, that's correct. Yeah,
Okay. Thank you, Mohammed. And the elbow is 90 degrees. You start the elbow in flexed position, I presume.
90 degrees. Yeah,
Okay.
90 degrees. And after you take the transolecranon wire, you can do
cannot
more
move the
you can do more
elbow.
flexion because you will broke the wire.
Yeah. I understand. Okay. And when
We
do you
have
remove the
we have
wires?
one broken wire from the 42 case.
And when do you remove the wires? 4 weeks as usual?
4 weeks. 4 weeks.
Okay.
Even the one we did operate him again, there was no affection on the range of motion of the elbow or all of this. We put this patient on the paper also.
Yeah, because like Mohamed Galhoum said, when you take the wire in the olecranon fossa, which we aim for, all of us, we aim for it. You don't allow extension because you already put a wire in the olecranon fossa. You have to. The extension needs to be done after you remove the wires. Needs to
Yes.
start after you remove the wire.
I will put the Indian paper
If you
on the
have a
group.
photo, if you have a photo
It
of your wire
No,
on
it's
the
already.
page, it will be easy.
Ahmed has bought in it already.
Yeah,
The
yeah.
link
Oh,
for
okay.
the
is,
shower.
yeah,
So guys,
yeah.
basically they take the lateral wire from the most distal point, so they catch as much from the epiphyseal bone. So you go through the cartilaginous cranium and then go. So you normally aim, if you want to put proper two wires, you aiming to diverge them. So what they do, maximum divergence. So one is going lateral and one nearly straight. So, but catching the medial cortex, I think in the paper Ahmed bought, I've seen the images in there. It's quite interesting idea. So, and I think we'll be waiting for the paper. A lot of us will be waiting for it. To be honest, the lateral wires didn't do any problem for my cases, so I'm still with the two lateral wires. But if this idea is doing the job, why not?
Yeah. I got another question. Do you put these wires, that the first wire, the transolecranon, on AP or lateral, or it doesn't matter? The X-ray.
You put it on the lateral. It's okay. Yeah.
Mm.
Yeah, you put it on the lateral view, so you can see the lateral view, and then because
And
to know if it's anterior or posterior.
yeah, and after that you will do an EB with, you know,
Yeah,
a
it doesn't
special
matter.
technique.
Because it doesn't matter for you. It's just like it can go anywhere.
Yeah.
As
Yeah.
far as that catch the distal fragment with the proximal fragment.
Yes.
Yes.
Yeah, because
It's very
Mohammed,
interesting.
I think the lateral wires are more technically demanding than the crossed wires. I see lots of mistakes about where to cross the wires. You have to cross the wires outside the patient bodies, the degree of divergence. Sometimes the wires are parallel, nearly parallel. Sometimes the wires are converging rather than divergent. So I see that the lateral wires are really technically demanding compared to the medial, the crossing wires. Although the crossing wires carries the risk of the ulnar nerve injury. So if you have a technique that carries the beauty of both techniques, that will be very interesting.
Our aim of the paper is not that to say that use this technique instead of the two lateral wires. No, we say that if you have a swollen elbow and you are struggling to do, and you might take many trials, and we have seen many patients like this.
Yeah, it's more difficult when the elbow is swollen. Yes.
Yeah, you can use a transolecline wire in those patients. This is the aim of the paper.
And Mohammed, did you include any biomechanical assessment for the transolecranean wire versus the two lateral or one medial and one lateral?
No, we haven't.
Okay.
We can do that for you, Mohammed. So just come out with the paper,
And we'll
Yeah.
make it.
test it biomechanically for you. I have a lab and I have everything ready for it. But because but I don't think the UK practice will not adapt it for a long time. But if it's doing the job, why not? So basically we need something to do the job with minimal risk. That's all. So if it's doing the job, why not? Ahmed is commenting on the wire breakage, and that's very expected. So I do MIS foot and ankle, and yeah, if you put a wire on a movable joint, especially if you allow the patient to move, or the patient is non-compliant with your advices, it will break. But
Yeah,
even
but
if it breaks, it comes.
we do that already for the normal supracondylar, Mohammed, because patient will be always in a splint, and within 4 weeks we'll take these wires out.
Yeah. But I mean, breakage will be expected, especially it's crossing the joint. So
But
it's
even intraoperative, if you do the transolecranean wire first, that means that you have to keep the elbow stable while you are putting the lateral wire, because if you moved it,
no, it will be stable. So it's already blocked.
Yeah, but I mean, you shouldn't move the joint itself at all.
Yeah, it's blocked. Yeah.
So yeah, you'll block it at 90 degrees and you'll put your lateral wire. Okay.
Good, guys. Very interesting discussion and a very interesting paper and technique. We're waiting for it. Guys, thank you so much for your time. We 15 minutes beyond the time, so that's very good. Was a useful discussion. Very nice two papers. So we may be thinking about changing the UK practice to a seasonal guidelines and policies based on Amr's appraisal for the paper. And then Mahmoud has flagged up a problem which initiated a lot of discussion. So we're waiting for Mohamed Ismail paper and for the technique. Guys, thank you so much for attending. And once we close once we close the Zoom, you will get the feedback on the screen. Please fill in the screen fill in the feedback on the screen to be able to release the CPD's certificates for you. Don't worry, the CPD certificates will be with you within a week. So don't worry, we will never forget you, because I got a lot of emails asking about the certificate. Certificate will be definitely sent. Just we need some time because preparing it and revising it, and we have to get everything according to the Royal College standards. Guys, thank you so much for attending. Our next journal club will be second Friday of March, and we promise you of a new two interesting papers with two expert appraisers, and it will be a trauma theme, so very interesting and very attractive for everyone. Thank you so much for attending today. Thanks for your time, and have all a good evening and a great weekend.
Just Mohammed to say one more time, if you're interested to present critical appraisal after June 2026, please email. I dropped the email in the chat box as well.
Yeah, so we need you all guys coming in and practicing, and you see how the discussion is going. And training yourself on the critical appraisal is not part of our basic training. Most of us, it's not part of our basic training, and it's something we need to train ourselves on and get more used to. And as I told you, it's very good credit for your research experience wherever you're applying for your appraisal, CPD points for your appraisal. So I think it's helpful from all means, and we strictly aiming to get it running qualified, regular, and non-stop. And hopefully you will help us to do that. So we're waiting for more critical appraisee to come in and appraise, or appraisers to come in and appraise our papers. So if you're interested to join from June to December 26, please drop an email to journalclub@orthoexcel.co.uk. And yeah, hopefully we'll see you all there. One more time, have a very good evening and a great weekend.
Thank you, everyone.
Thanks, guys.
Lots.
Bye.